So let's think about the P in RPM ABC, our mnemonic for 12-lead EKG analysis. The P stands for P waves, follows right after rate, which we should have covered by this point. And then later we'll deal with M for measurements, we'll do axis and bundle branch block together, and finally C for changes in ST and T wave. But our focus right here today is on the P in RPM ABC. So P waves are about conduction, so a conduction system review seems to make sense. Remember that we have an electrical conduction system in the heart because we need the atria and the ventricles to be synchronized, and the way we do that, we synchronize their contraction, is with the electrical conduction system, and we synchronize that contraction so the atria contract first, stretch and fill the ventricles to the max, and then the ventricles contract, and the conduction system allows that to happen. So we're very interested in P waves because we want to be able to determine if we have good synchronization between the atria and the ventricles. So we want the P waves to cause the QRS. We don't want a QRS without a P wave. That would mean that we didn't have good synchronization. And by the same token, we don't want a P wave to be hanging out that doesn't produce a QRS. So conduction system issues promote good cardiac output, which promotes good blood pressure, which promotes happy patients, and we need to watch for P waves to help us with that. Remember that the P wave represents atrial depolarization, so that's an electrical event, and we believe that that event is associated with atrial contraction, a mechanical event. Where do P waves come from? Well, we want them to come from the SA node. Sometimes they come from other places, but we really want them to come out of the SA node, the sinoatrial node. Sometimes they come out of an ectopic atrial focus, which is an extra focus. It's not the SA node. It's some site in the atria that fires. Sometimes more than one of those ectopic atrial foci are firing. Sometimes there's no P waves at all. When you're hunting for P waves, you want to sit and watch lead V1. That's where you want your focus. The best camera view of what's going on in the SA node is the camera that's right over the SA node, right over the right atrium, and the lead V1 is your best. Now, some people like lead 2, and it's an okay choice, but it's not near as good as V1. What are we looking for? Well, we're looking for shape. And the EKG word for shape is morphology. So we want all the P waves to have the same morphology. We're not really as concerned with what that shape is. It just needs to be the same shape. And so the theory is that a different shape would indicate that a different focus is firing from a different place. If the sinus node produces the P wave, we call it a sinus P wave. So the SA node produces sinus P waves. Sinus P waves should be upright, mostly upright in lead 1, lead 2, lead 3, lead AVL, AVF, but inverted in AVR. So the left side of the 12 lead, the limb lead side of the 12 lead, with the exception of AVR, the sinus P waves are upright, and sinus P waves should be inverted in AVR. The next thing we look for is there a P for every QRS? Are there any QRSs that a P wave didn't appear to cause? If the QRS came out of the ventricles, no P wave would have caused it, and that tells us that something's not normal in the conduction system. Remember, a normal conduction system means good synchronization between atria and ventricles, which leads to good cardiac output, which leads to good blood pressure. The other question we ask is, was there a QRS for every P? Were there some P waves that did not generate a QRS? The P wave was dropped. In other words, it did not conduct. Sometimes a P wave doesn't make it through the AV node. Now, the AV node's our friend. We're very happy with the AV node, but sometimes the AV node doesn't function right, and it eats P waves. We need P waves to go ahead and conduct because conduction system issues lead to good synchronization, which leads to good cardiac output and good blood pressure. Sometimes there's no P waves at all. That means that the atrial depolarization didn't happen. So we didn't get the atrial kick. The atria did not contract. They did not stretch that ventricle, give its maximum ventricular filling, and we don't have good cardiac output. So now we don't have synchronization. We don't have good cardiac output, and that can lead to a bad blood pressure. So why were there no P waves? Well, maybe it was an idioventricular rhythm. Maybe the rhythm started in the ventricles, so there shouldn't be P waves because it started in the ventricles. Maybe it started in the junction. the AV junction. So just south of the node and north of the bifurcation there at the bundle, maybe it's a junctional rhythm, or maybe it's something called atrial fibrillation. Some QRSs have no P wave. Maybe it's an extra beat. Maybe it started in the ventricle, so it's a PVC. Maybe it's a PJC. Or maybe it wasn't an extra beat, an ectopic beat, an early beat. Maybe it was a backup beat. Maybe the SA node didn't function, and so then the junction kicked in and produced a junctional complex that really was called an escape beat because it helps you escape death. Or maybe the SA node didn't function and the backup at the junction didn't function, and then we were left with a backup to the backup, a beat coming out of the Purkinje fibers, and so that would be a ventricular escape beat. And that can be a good thing. It indicates there's a conduction problem, but we like those escape beats because they help us escape funerals. Some P waves have no QRS. Why would that be? There would be a P wave, but it didn't generate a QRS. That means the AV node ate it. Typically, this is a second degree AV block, a Mobitz 1 or a Mobitz 2, and what I just said was a foreign language probably at this point, and that's fine. We'll spend plenty of time on that later, but just realize that sometimes the AV node doesn't allow all the impulses through that should be getting through, and so we have an AV block. That's a conduction problem, and that might be a big deal, or it might not. Whether or not it's a big deal is all about the rate. It's about how many complexes are being generated, how many P waves are getting through and making a QRS. So what causes P wave issues? Well, sometimes the SA node's just a little sick, a little tired, needs some oxygen, needs some electrolytes, and it'll come back around and start functioning right. Sometimes not. Sometimes it's old, damaged, and it's just not going to work. Sometimes the SA node's ready to work just fine, but the little ectopic foci, one or more of the little extra pacing sites, just starts firing away in the atria. And so you figure the SA node likes to, its intrinsic rate, it likes to fire at 60, 70, 80, something like that. Maybe it's all nice and ready to go at 80, but the little ectopics keep speaking up 90 or 100 times a minute. And so the SA node would be happy to speak if it were allowed to, but the little ectopics beat it. Last concept I want to deal with this particular screencast is this concept of regularity, and this gets into a tongue twister of complex terms, but here we go. Rhythms can be regular, and we like those. Those mean good synchronization. Everything is good as long as the rate's all right. Or they can be regularly irregular, where there's a pattern, and it's a regular pattern, but there's missed beats or skipped beats or something that occur on a regular basis. It is a regular pattern of irregularity. Or there's just chaos, irregularly irregular, which would be atrial fib in most cases, an irregularly irregular rhythm, where there's just no patterns. The rate is all over the place, and the rhythm is not normal. So again, irregular rhythms would tend to make us think that there's not consistent synchronization between atria and ventricles, which would then lead us to maybe a decrease in cardiac output, which may impact blood pressure, and it all may be a big deal. Regular rhythms are the norm. That's what we want. So what would cause an irregular rhythm? Well, it could be extra beats popping in early, premature complexes. Whether it comes out of the atria and it's a PAC, it comes out of the junction, it's a PJC, or it comes out of the ventricles and it's a PVC. Premature complexes, they're jumping in early. That causes irregular rhythms. Sometimes there's total chaos in the atria, atrial fibrillation. There's no atrial contraction going on, so we've lost that atrial kick, which is probably 10 or 20% hit to our stroke volume, which probably means, unless the rate goes up a lot, a 10 or 15% hit to cardiac output. And so atrial fibrillation we're not real happy with. Now, as long as the rate is reasonably normal, in the 70s, 80s, something like that, atrial fib is tolerated, at least from a cardiac output and blood pressure standpoint. There's other issues with it, like clot formation and such. But as far as the cardiac output goes, atrial fib at 70 is tolerated. Atrial fib at 140 is not tolerated well. So irregular rhythms can cause us problems with cardiac output, and that's the big idea here. What's another cause of irregular rhythms? Well, be an AV node. The AV node is eating one or more of the P waves as they come through, and so we have the AV block issue. Now, there's 4 types of those. We're not going to focus on that now. There's plenty of time to focus on that. Have a whole screencast or two just on AV blocks. They seem to be kind of confusing and scary to medic students, but we're going to help you get through that. But for right now, think of 3 things can cause regular rhythms: premature complexes, atrial fib, or AV blocks. So, is this a big deal? Should we be concerned? Do we really care about P waves and QRSs? Well, yeah. As far as the BP is concerned, irregular rhythms may be an issue because of the lack of synchronization between the atria and the ventricles. Doesn't get the ventricular stretch, a little bit of a decrease on stroke volume, which causes a cardiac output problem, which causes a blood pressure problem in some cases. But other times the irregularity is just kind of entertaining. It's just not scary. But it all depends on the rate. If you think about it, if the ventricles are getting an impulse at 70, 80, 90 times a minute, they're probably producing a decent blood pressure. But if they're only getting an impulse at 20 or 30 or 40 times a minute, they're probably not producing a good blood pressure. So regardless of how many P waves are happening, if they're getting through and making QRSs 60, 70, 80 times a minute, it's probably okay. They tend to produce a lower stroke volume when you get an irregular rhythm, and so that can be a problem unless the heart rate increases to compensate for that lower stroke volume. Remember, it's all about cardiac output. It's about stroke volume times heart rate. So if the stroke volume goes down, the heart rate's got to go up to compensate.